Hello, good morning, everybody. Welcome to the 18th edition of the Health System Fix podcast. My name is Dr. Gaurav Mishra. I'm a child, adolescent, and adult psychiatrist and a health systems design expert. I'm very excited to welcome Elizabeth Morrison today. Every time we talk about health systems, and it is so it's so exciting to have that conversation with Elizabeth. I'm looking forward to this podcast today. Elizabeth holds a PhD in social psychology. She's a licensed clinical social worker, also possesses a master's in addiction counseling. She has more than 30 years of clinical experience. She's also the CEO of Elizabeth Morrison Consulting, a company dedicated to enhancing human connection with health and social care. She's the co-creator of Lay Counselor Academy, which we'll talk about quite a bit today, an initiative that aims to expand the behavioral health workforce and ensure that high-quality mental health counseling is accessible to everyone in need. So I'm very excited to have you on, Elizabeth. Thank you for joining me.
I'm super glad to be here. It's always really fun to talk to you.
Great. I like to talk to people whose ideas are different and exciting and aim to make changes in our health system, which is needed. At the same time, I know that ideas are something that evolve over time. So I like to understand the context of how you've come to where you are today. And something I would love to know is, can you tell us a little bit about what was life like growing up till you thought about college or professional life? What was that like?
It's such a great open question that I have to really think what comes to me. Well, I grew up in Alaska, and I was born 1970s, 70s and 80s in Alaska, still very much the Wild West, had just become a state just I don't know, a decade earlier or something. And I think what is a couple things are that are significant about Alaskan culture, especially back then, which is the trades had much higher status than professions. So I grew up where the social status that we see in what we call the lower 48 in the rest of the US was tipped the other way. So plumbers' kids were like the rich kids in my school. Carpenters or fishermen were the people who made the most money and had the most autonomy over their schedules. So it was the most desirable, jobs to have. So, and, my parents didn't go to college. My dad's an immigrant from Scotland. He didn't finish high school. So I think I didn't have much stock in college or professions. I definitely saw the trades as the most desirable place to go into. And then I think in my family, my dad had really severe alcoholism and my mom had a severe hearing impairment. So I grew up like very, very hungry to be listened to, having that experience where like neither parent could listen or hear. And then I kind of found out that there's an entire profession based on listening, an entire profession where treatment is based on listening. Um, and I think it really captured my imagination because I always wanted to be the person who could really listen to others so people didn't feel like I felt when I was a kid.
Wow. The context of you growing up in Alaska and how you describe, I think it's so interesting that where does the desire to listen to others come from? Before we jump into the education piece, how long did it take you to get to a place that you felt listened to?
Yeah, such an interesting question. I too have alcoholism and I got treatment like most people don't. I had multiple treatment episodes. It's really uncommon. Of course, we know how rare that is. 1 in 10, I think, get treatment, as if you're a person of color. I did have multiple treatment episodes. And I do remember having a realization when I was in one specific treatment center. They were of varying quality. And one specific peer, they wouldn't call them peers then, it's just a recovering person who was a counselor. I do remember being so like overwhelmed by being able to just talk and realize someone could stay focused on me and not have to advise, not have to fix the feelings I was talking about, could just listen. I still remember her name. Her name was Catherine. Like, she made a really deep impression on me. But I think before that, because of my family life, I found solace in friendships. And I had a friend named Marty Joe when I was 8. And she was the first person I ever told that my dad had alcoholism. And as an 8-year-old, she was shoulder to shoulder with me. So we weren't looking at each other. And I told her, and she listened, and she told me she was sorry. She didn't do anything else except listen and tell me she was sorry. And then we ran off to play. That really, really made an impression on me as well. Just that I could tell people because afterwards I felt so much better. Gaurav. I remember being 8 and being so relieved and feeling like the world was better and like the flowers were brighter and the birds but yeah, my dad was still an alcoholic. Like nothing changed in my life, but the experience of sharing it with someone who loved me and who could listen transformed how it felt.
That's so beautiful. I thought about this maybe about 2 years ago. I had a patient who sort of lost her teenage son to suicide. And she came in, and I had been her psychiatrist for a while, or just, for a few months. And I was just like rattling my brain. What am I going to do for her? I heard about this. I told her, come. And then my initial thought was, do I have a solution for her? Right? Obviously, I do not. And then I realized in that moment, the only thing I can do, and the most effective thing I realized I can do, is actually just be another human who is listening to her without judgment or trying to find a solution. Oftentimes people try to find solutions because they have anxiety and they want to help you and they want to fix it so that they can also feel okay. But I think in that moment, I realized, okay, none of my medical training is what is needed here. The only thing I can do, and actually the most effective thing, is just be another human who can listen and witness like what's going on. And that is so effective in itself, which we don't always do.
It's so powerful. And I think, like you said, it's so rare because I felt it too, of course. Most people feel the urge to do something, and listening doesn't feel like doing something. But losing a child to suicide, that idea of a loving witness, being sort of what is called for in these situations of such deep suffering.
I think witness is the right word because of so much of our lives, everybody's lives, including all of us who are trying to help others also, goes unwitnessed, right? Telling somebody, one of my teenage patients back in my second year of residency told me, "Oh, you're just like a paid friend." And I was just like, a new physician, and like I thought, paid friend. Initially, I thought, okay, is this a compliment or not? But I realized it's a huge compliment. If this person trusts me and even can call me a friend, that itself, I've done my job there to be able to make them feel supported. It is not about my medical skill set there. It is about the human skill set.
I love that verb befriending. It's just I think it's such an interesting verb. I'm always trying to use it, but I can't figure out how to use it, but it's always in my mind. But you were befriending, and that client recognized that. Yeah.
And I think that's also, my brain is just going off in directions away from the questions. Is I think that may be also a way to reframe how we do clinical work, because that actually brings us to, we often talk about meet the patient where they're at. A friend meets their friend where they're at. So that approach may make us get there.
If we pair it, because meet the client where they're at is like a mantra for us. And so if we sort of paired this sort of befriending and loving witness work, maybe it will be something that's more common. Because I don't know how you feel about this, Gaurav, but I feel like even in our field, it's uncommon. As therapists, you feel people wanting to fix and pitching solutions. And
a good friend also calls you out when you're doing something wrong. So I don't think it means you're losing that professional thing, because you still do that.
Good friends are honest. They're honest with you.
Again, we can talk for hours, but you realizing, there is this profession out there. So what was that path for you to kind of consider education, healthcare?
Well, back to the last treatment episode I had where I was able to stay abstinent and get into recovery and join 12-step groups, which I'm still a member of. And I got into the addictive disorders field through lived experience, which is not an uncommon pathway. Although in Alaska, there is no social model. So treatment is not based on peers or people with lived experience. So I did apply to work as sort of an entry-level person in a treatment center. I had been just waitressing while I was in my addiction. I couldn't go back to that. And I knew somebody who worked in a treatment center who had had a lived experience with addiction. So I applied, but you don't put it on your resume because it's not relevant to be considered. But I ended up working in a treatment center, at this entry level, and I just loved it. I just loved it. I think it was one of the first times I had what in AA we call freedom from the bondage of self, where we all I feel like we all need to find those things in life, whether it's like art or music or our vocation, our work. Where do we get freedom from the bondage of ourselves, of our small selves and this discursive thought. And when I would talk to people in this treatment center is for adolescents, I would totally forget myself. I could really just stay focused on this other person. And it was so relieving. And then I got a lot of feedback from people who felt like I had skills. And so I got a lot of self-esteem from it. And then somebody said, if you don't want to go back to waitressing and you don't want to stay at this entry level, you probably need to go to college. Which I didn't have any models for that. My siblings didn't go, my parents didn't go. So I got a bachelor's degree in sociology. And then I went back to work for that treatment center as like another kind of level of counselor for years in Alaska. It's an amazing adolescent treatment center there. It's a huge part of my life. And then decided to go on and get a master's degree and get a license. And then I went back and I was the clinical director of that treatment center for many years. So those places have a special place in our heart, the places where we grow up professionally. And that was mine.
Yeah, I was thinking last few days, I feel lucky that I'm in a career transition, but I'm working a couple of days a week at the juvenile hall here locally. I love thinking about, as we've talked about before, I love thinking about systems work, systems change, all of that. But some of that work is obviously difficult, and the time horizon of getting that done is longer. And sometimes you can't measure fully how effective you're being. But I know every single Monday and Tuesday when I'm at the juvenile hall, those days are amazing, because when I'm with the kids, I'm 100% there and putting all that I have in it, and I'm trying to connect. And when I finish that session, there is almost a bow at the end of that. Okay, we've done this, and it is hopefully helpful. It is definitely hugely satisfying for us to do that work. And such a good way to just keep grounded.
Like you said, Mondays and Tuesdays, you feel like there's something so concrete about being with one other person. And like you said, giving it your all. And then at the end of the session, it almost feels like there's a bow, like we gave it everything we had. I would say like we left it all in the field. You're kind of all in. It's really rewarding. And I also think we have a poverty of connection for a lot of folks in a lot of areas of our, society, of our country. There's sort of an epidemic of loneliness, a feeling of disconnection. There's really high social distrust. And I feel like we get to feel really connected, even though it's not a reciprocal kind of relationship in the same way a friendship would be, where we're also sharing about ourselves. It is a type of connection where we feel very connected to people. And it does help with, I always feel like I have like such a high dose of connection. And some of it comes from this work, individual therapy work.
I think the connection piece, um, I don't necessarily think it's necessarily transactional. It doesn't need to be transactional for it to be satisfying, because I think the human connection piece is probably it's a cumulative. Whereas, because I'm also thinking like there are many relationships which have certain roles in your life, and they're not all everything. Not everybody is everything, right? And so, if you just spoke to your therapist who listened to you all the time, and you are not somebody listening to somebody else, that's incomplete too.
Yes.
You have to have all of it. You have to listen, and sometimes obviously good friendships are where you can do both. But I think probably the human connection piece is more cumulative, that it kind of does add to your human connection pool that you need to kind of be a human.
Yeah, and the other part I hear you saying is like it's cumulative, and so we get to add that to our sort of people in our field. And I hear you saying like it's varied, different types of connection, different ways of connecting. When we're listening, when we're in that position, our clients are also in that position with others. Those loose connections in the community that we know that are so important, where you're recognized. Like I just left my grocery store, and I'm like, I've been walking to this grocery store like 3 times a week since my kids were little, and like there's that recognition, like, hey, and we're not what we normally define as friends, but they're those loose community sense of belonging that also is part of that accumulation that is so important, I think.
So again, this is not a question I had thought about, but like your thoughts on it. You have a empathy bank in your mind, heart, body. And obviously, especially in the helping professions, not just therapy, all of that, the PCPs and everybody in healthcare and other professions, you are constantly giving so much. And you have to do a good job, you really have to give a lot. And if you don't, want to do a good job, which also happens, unfortunately, it's easy.
Yeah.
And so I've seen a lot of people who are amazing at their work have not kept up with replenishing their own tank, and it kind of over time it just gets to a place that they're not in a position to be the same amazing healthcare professional that they were. And I don't know if you feel like that's such a responsibility, obviously to yourself, to your family, but also to your patients, that you need to make sure you're taking care of yourself along the way. Otherwise, it's going to be short lived.
Gonna be I was just talking to a colleague in the field about this, about how like our own self-care and our own personal growth and how we are the only tool in therapy. You're a physician, you're also a prescriber. You have other tools in your toolbox. And I know like there's a big part of your heart that is like ultimately a therapist. And then of course psychologists, LCSWs, LMFTs, LPCCs, like people who don't have licenses who are kind of naturally doing therapy. It's all we have is us. And I do think they're probably, I'm guessing, probably engineers, when they're caring for themselves better, also do a better job. So maybe it affects in every profession, but I do feel like with us, there's like a direct link, in these helping professions for how we are doing and how effective we are. And you're right. Like we do have to give a lot to be effective. And it makes me think about the way that you and I have both worked in fee for service systems, and that is where most helping professionals work. And so, including it, whether if you're in private practice, but certainly if you're in the safety net. And the way we structure these professions in this capitalized healthcare fragmented, like largely for profit. And then, of course, the public health plan. But the US, it's largely corporations for profit that are capitalizing on healthcare, which means that we're paid per unit, which means that there's intense pressure for organizations that's the only revenue they have to make sure that we are seeing patients all the time. You have to manage how long lunch hours are. You have to manage how long meetings are. You have to manage how much time you have for continuing education. You have to manage every minute of time that is not spent in front of a person, because that is how we make money and keep the doors open. And it's not even cynical for those of us who work largely in the safety net. It's keeping the doors open for the mission of this organization, not even for stakeholders to make money, for stock owners to make money. But it's antithetical to what we know about how we can remain as well as possible so we can continue to give as much as possible. And that is that I don't want to generalize too much, because I think it depends on age and it depends on what our home lives look like and maybe temperament. But I think that I think it's a finite amount of time that we can see patients full time, 9 to 5 every day, 5 days a week. I think it's finite. I did it while I was younger, and then I had small kids, and then I kind of faltered with that in terms of feeling like I was not giving as much as was needed and not doing as good a job with clients. And then there's some moral injury there, so I had the freedom of my job to, reshuffle and say, I don't think I can do this 5 days a week. And then when I became a leader, and I think you did the same, trying to figure out with my own people, okay, can we spring you one day to run groups even, which is a totally different, energy? Can we spring you one day to do some administrative work that's really interesting and fascinating to you, to build a system? But I don't know how much longer we can all go on doing 5 days a week, seeing as many people as we can for years on end.
Yeah, I think the 5 days a week, the problem is the way it is structured. I think if you are structuring it so that the system has enough flexibility for one, the patient walking in, right? Is this a patient coming in with their daughter and they just got diagnosed with dementia and they're very scared? They're not going to be done in 10 minutes. They shouldn't be done in 10 minutes, right? Patient who is doing well needs refills and fine, right? So, and the other piece of it, which is I think more important to make this happen, is the flexibility for the team. How is the
Yes.
team functioning that day? I think the problem is our system doesn't expand and contract like it needs to meet the variation of patients and provider variation that can happen. And it's not human centric. It's not human centric for the patient or the provider. Frankly, it is not. It is not set up, and that's true for a lot of nonprofits too. Frankly, I think it's not set up. You know, for-profit systems and nonprofit, they're seeing the same number of patients. It's not like
It's true.
so. It's not how it should be designed. And so I think that is why the burnout is just so quick. You don't have to do all your life's work in the first 5 years of your career.
It's such a kind thing to say. Like, it's okay.
Yeah, and if your goal is to really serve the community, people would do that for 30 years, 40 years, and you're taking care of yourself along the way. And so you can get there. I appreciate the passion. I appreciate the drive, but you're not taking care of, you're not going to get to that level of impact that you actually can have.
Yeah, it's almost like you're kind of coaching them like you're in a marathon. If you want a lifelong, career in this, being able to continue to do these direct one-on-one services, it's such a marathon. Because you said that like there's an empathy bank and there's an energy bank. And then that does, do this throughout life, depending on what we have going on. When we're going through like really tough divorces, when we have really a high needs child or multiple little kids, and we're the primary parent, there's so many different things where our energy oscillates, and like having a system that can flex with that would be more human centered. And then, like you said, for patients, it's not human centered either, because they're also kind of in this slot that isn't assessing what they actually need. And it makes me think about the 50-minute hour, like how our field got so wedded to the 50-minute hour that we decided somehow. And then when integrated behavioral health came, we got super wedded to 30 minutes. And they're both not wrong and they're both not right. It's the idea that we got wedded to that's sort of the number, as opposed to figuring out like, how can we build something that is more flexible to what people need and how clinicians can run a marathon, can sort of keep pace and be well.
And again, that's just that's just a reflection of the incentive system. Let's spend a little bit more time today to make sure you don't need 6 more appointments, soon after, but that does not incentivize. So let's go to a Golden Valley Health Center where you were the chief behavioral health officer for 8+ years. What is that transition and experience like?
It was a really significant change for me because I had only worked in what would be considered very traditional settings in dual diagnosis treatment settings, residential treatment settings, outpatient treatment settings. So it was the first time I'd ever worked around physicians or nurses or medical assistants. I didn't even see doctors myself in my personal life. And I know that's health privilege stuff, like it, they weren't really a part of my life or my ecosystem. I didn't have friends, colleagues, anybody in my personal life. And the CEO of Golden Valley Health Centers, his name was Mike Sullivan. He was a Peace Corps worker who came out and set up, he marched with Cesar Chavez through the Central Valley in California, where I still live, and started this community health center to treat farm workers in Merced. And like a lot of old school, like all that first wave of CEOs for the community health centers, across the country and in California, were just kind of these amazing social justice folks. And there's a disproportionate amount of them that were in the Peace Corps, and, were out protesting, with MLK and Cesar Chavez and Dolores Huerta. So when he called me in Alaska to recruit me, I was just totally enamored. I was looking to leave Alaska. Too dark, too cold. I was 35. I had a little baby. I was just ready not to be so isolated, but it was the mission. And he asked me if I could start integrated behavioral health. And in graduate school, I had gone to graduate school at UCLA, and Venice Family Clinic had something very close to integrated behavioral health long before the field took off in California. And so we had a little pager, and physicians would call us and we would walk into exam rooms, and we would sometimes just do therapy in exam rooms, sometimes take folks out. So I had a little sense of what that might be, but it really wasn't done for the most part at, any other FQ that I knew of except for Venice Family Clinic. But I do want to give credit to all of those, like the folks who were doing HIV treatment in the early age years. Anybody who's done kind of really wraparound services has worked in what we now call integrated behavioral health. But the biggest culture shift for me was working with medical personnel. It's such transactional care, even though the people in it, what therapists I think have in common with the medical field is the helping professions, the heart of it, the growing up wanting to help people. And this is just the path you took and the profession you took, but we're all in the helping professions. So as individuals, I had this affinity, like this values connection immediately. Like, I get you and they got me. But the care is so transactional. And I was shocked by how transactional it was. That, this idea of, it really isn't, the system is not set up for two humans to meet together. The system is set up for a patient who is a receiver and a provider who provides. And that is a business transaction. And if the patient doesn't take it, they are non-compliant. And the job of the provider is to provide. It's not to develop a relationship. It's not relationship-based care. Your job is to provide in a transactional sense. And so I saw all these amazing values-driven, mission-driven people in this field, in a field that's medical field is much more transactional than the mental health field. We also struggle with that, and there's been a medicalization of the mental health field. There's no doubt. But there's never any question that our entire field is based on relationship, because the research for 150 years, back to Carl Rogers, is that our patients cannot get better. They will not get better, at least not from our help, unless we have developed an empathic relationship. So I feel like we might get off course and things have gotten medicalized in some ways, and the diagnosis industrial complex that's tied to the payer system is a big problem. But I don't think anybody forgets that our profession doesn't work without this. And in the medical field, I feel like it's treated as an afterthought, that it's not primary. And they suffer. The medical field suffers, and so do the patients in those systems. What are your thoughts about that?
I think their medicalization or maybe industrialization of their work happened a few decades earlier than ours started to happen. I do think the PCPs you hear about from your patients, oh, this doctor is amazing. All of those people you hear about are for sure people who are going above and beyond, because the system is for sure not set up to do the human work. And I think when we look at PCPs having to see 24 patients a day or like 6 patients an hour, by the way, they should ideally get their notes done in that time. So the average time spent by PCP is probably 7 minutes or less per patient. And if we had 7 minutes to check about everything for our patient, we would talk about suicide, homicide, psychosis, because without that, we can't have this patient leave, because we have to ensure the safety. So they have to do all the critical system and make sure labs are fine, blood pressure, all of that before this person leaves. And this was initially frustrating. That why aren't people doing it the right way? And then you look at how they're set up to do it. You give the same PCP, which, by the way, ChenMed, which is a model for in like primary care, they have caseloads for PCPs, 500 patients, not 1,600 like most FQs have. Okay. They see every patient, irrespective of the situation they're in, they're seeing once a month by their PCP. And every patient is seen once a month. They're at least seen 11 times every year by their PCP. Maybe 1 or 2 times in that year is by a nurse who's part of the team, which is, I think, essentially the same system. So those patients have reduced ER visits, reduced hospitalizations, reduced complications, because these PCPs have been assigned patients.
And they have a long-term relationship with patients, accumulation of much more time, because the average patient sees PCPs 3 times a year. So that's 21 minutes normally. And you're talking about a once a month visit. Yeah, I think thinking about radically different models. And just to segue back to mental health, I feel like integrated behavioral health within primary care, there is this danger, and I've seen it, and I bet you've seen it too, where the therapist picks up the very broken transactional culture and immediately is told they need to see 14 people a day, and they need to see people for 16 minutes each, and they need to do the screener and do the suicidality. And so they've just absorbed the problematic parts of medical culture that even the people working in that medical culture know are problematic and are working sort of in spite of it to connect with their patients. But I saw a lot of integrated behavioral health programs go that direction, where they just absorb the medical culture. So I feel like there is something about this model that you're talking about, this kind of radical model of a third of the size of a case load and much more frequent contact throughout the year, and a real team approach and keeping the same team. And I do feel like the integrated behavioral health departments and integration that has been successful have kind of a radical reimagining of what mental health looks like in primary care. We do not adopt the broken things about medical systems, but we also don't sit in our office and say we're only seeing 50-minute folks and we need an hour and a half for assessments, and don't knock on my door because I need perfect predictability and I will see 4 people. Like, we can't do that either, because we're public health professionals as well. Primary care is public health. We're public health professionals, and we'll end up seeing a couple hundred people a year. whereas our community clinic has 50,000. So, so we have to start thinking more public health. But there's I think a reimagining of what relationship based public health care can look like when it really works, when the magic of integration really works. And it is magic because I would come home and tell my husband at the time, he'd be like, "How's your day?" And when I was at Golden Valley, and I would say, "I feel like the Jedi." Every day I walk into an exam room and see someone who has never seen a therapist and would never see a therapist in the whole time. And I have amazing sessions and I have colleagues I can talk with and we can work together because there's a team. And I'm seeing kids and I'm seeing like a 60-year-old farm worker who um, doesn't even use the word depression, and we didn't have to use the word depression as we were talking about how to help. And, it's an amazing model of care when it works, I think.
Yeah, I'm thinking that if you are a mental health professional and you've been asked to lead this integration work, your first task is to heal the medical team, because
Yes.
they themselves have been so under-resourced, overworked for so long. A lot of my thinking around building programs was, I know the patients will be well served if my team is well supported, because that's what these people are here for. Same for the PCP team. I think a lot of times and I see so many teams claiming integrated behavioral health is definitely not integrated and it's not supported. And each team is kind of set up to just fend for themselves. Like you have to have this productivity and you have to see these many patients, but make sure you talk to each other, like when, right? Which just kills the opportunity and the culture of integration. The whole talk about integration is not maximize patient, is actually help each other and then help the patient in turn. I would have our team tell me like, the PCPs are not kind of meeting us midway. Sometimes you may have to go a little bit more that way initially till people start seeing, oh, this is not just helping the patient, it's helping us, this is helping the whole system. And I think not an easy role, but I think that's one way to approach it.
You're almost like framing like the first job is to concretely practice empathy with the medical team. To really understand. And I feel like, especially never having worked in a medical system before, I had no sense of the crushing burden of mental health. All kinds of conditions, but just looking at, 80% of PCPs prescribe, 80% of our psychotropics, right, are prescribed by PCPs in this country. They are the mental health system. They are the mental health system. And then on top of that, they're also supposed to be the entire public health system and the entire prevention system. And a lot of specialty because there's no way to get into specialties and especially in these safety net settings. And so I think just really seeing what it looks like to try to see 22, 24 people a day and try to give them the care they need and like acknowledge the mental health that they were providing, that they have been providing. I also had this experience that you made me think of, which is I had a physician who was a friend there who became a really close friend. And she said, I have to leave. I'm burnt out. You've seen it. We've seen it. It happens with therapists too. I'm so burnt out. I have to leave. So overworked. And I said to her, I just got this grant. It's like $100,000. It's not very much, but I get to do whatever I want with it. And what I want to pilot is I want to give a primary care provider one therapist of their own. So, just a 1-to-1 ratio. We always talk about, sometimes people say they have integrated behavioral health when they have one therapist and they have like 15 PCPs, 5 therapists and 100 PCPs, so it's very hard for PCPs to feel like they're really being helped by these integrated therapists when they can't get their patients in to see them. And so I just had one of the therapists on my team work with this physician all year. And this one therapist saw 80% of her caseload, her 1,500 panel, and was just that, they just work together all the time in and out of exam rooms and referral, not even referral, sorry, just back and forth, back and forth, back and forth. And at the end of it, she said, I will never go back. I can't go back. What are we going to do I know the grant's gone, but I can't go back, And I just thought, yeah, like they've gone so long without, of course, the medical assistants, the nurses are amazing and are just holding so much on these teams. Specifically with mental health, though, they really haven't had significant support.
Yeah, and even as a physician who's able to prescribe, last couple of years, my thinking now is the most important tool I have is my human connection. more important than any medication. Yes, there are patients who need medication, no question. But that is not, even a patient who absolutely needs medication is not going to take it if we don't have that human connection. So everything is dependent really on that. And then
Everything.
from that, you can build all the other things that are needed.
In fact, I talk a lot about the fact that the relationship with the prescriber to the patient dramatically impacts adherence, which is what you're talking about. If the relationship isn't sufficiently empathic or the patient isn't feeling it, then they won't take it, or they won't take it as prescribed, or they won't tell you they're not taking it. But I just read some research because I'm really fascinated with placebo research. And in our field, it's mostly called like expectancy research. If we expect things to work, the changes that our body physiologically then undergoes when we expect this thing to work. And I just read this research that depending on the relationship with the prescriber, the patient's body responds differently to the medication because of the expectancy effect. So, when you have this sufficient empathy with the patients that you're prescribing to, not only are they more apt to adhere to the way that you prescribed it to be taken, but their bodies are actually, they're actually responding to the medication differently and more efficiently, which I just think is fascinating.
Yeah, I think even just the value-based care piece, I feel like our whole care delivery system needs an overhauling. If you just change the money model of the value-based care and try to do the care the same way, it's not going to be value-based because our system currently is set up to meet the incentives that are currently there. A new incentive structure with the same model doesn't work. And also, it's not a great model necessarily.
Yeah. So you're saying, like, even if we change the whole payment system, that isn't necessarily change the actual model of care.
We have to change. So for the new payment system to work, the model of care has to be different. The current model of care with just a different money flow system does not create value. I don't think the current model of care is a valuable model. It doesn't create the value that we're talking about for our patients. If you want to create true value and then the money aligns to it, I think there has to be a different clinical model. Right. Yeah, we obviously are seeing physicians or nurse practitioners, we're seeing all of that, but how they work together, what are the touch points, whose effort is getting paid, all of those has to be restructured. And then I think we can get there. But the same model, if we just like continue seeing patients the same way we're doing, we're not going to get to value-based care, even if the money structure changes.
I really agree with you about that.
So let's go to, you were there for a while and then you leave. So I'm sure that decision was not easy to make. And what is the impulse for you to then start your own consulting?
It's not easy. You and I have talked as friends about that. It's not easy. I'd worked for my whole career up until that point, had been working for nonprofits. And so I never saw myself as someone who would have my own business. I always saw myself as working for nonprofits in the safety net. But I think it was partly that I too was burned out for all the reasons that we were talking about. And it's a different I did burn out with 5 days a week seeing patients all day long. And then there's a specific type of burnout for clinical leaders that I think is very familiar to any discipline of clinical leader, where when you're holding the administrative and, the quality and the safety piece for these, huge teams and seeing patients. And I think that when I looked to go to, when I knew I had to leave, just something had to change. It was a little Seinfeld-like because I loved my organization. I was like, it's not you, it's me, like you're great. But I can't kind of continue to work like I'm working, and I don't know how to ratchet down in my position. And I had a great assistant director, and it's time to move on and let younger and newer people in these leadership. There was also a piece of that where it's like, I don't think I'm the only person who could do this. And so here's these other folks. Sometimes there doesn't have to be anything wrong to want to go on to the next thing. But I did think the next thing would be another organization. And then every time I looked at other organizations or they came and talked to me about working for them, I couldn't get excited about it. Could just feel my head would say, this sounds good. And my heart would say, I felt almost like a sense of dread. So it's just one of those times in life that I think most of us have where making a decision that doesn't make a lot of sense in your mind, which means including it doesn't make a lot of sense maybe to the people around you. And so having to kind of follow whatever this feeling is when it might not even make sense to us is really scary. And it's really scary when it involves finances. And I am the earner for my family. And so that's, like you are. And so I think that's a whole different calculation about financial fear. But I think I kind of followed my heart, which is I don't think I can go into another organization right now. So I always thought being on my own and doing training and consulting for a while on my own was a bridge. I thought it was a placeholder. I thought I could have a little more control over my schedule, spend more time with my kids. Had a husband who passed 2 years ago who had significant health problems during that time. I felt like I could be, more available for that. And I would rest a little bit and figure out what organization next that I wanted to work for and then even see if I could. But I think what came out of that is I felt like I could do really good work. I could still see patients. I was still seeing patients at my primary care. So I didn't lose that piece, that Monday and Tuesday piece that you talked about, that you feel so relieved and so it feels so rewarding. I still had that piece. And then I could work with these other organizations, helping them with integrated behavioral health or doing motivational interviewing training or trying to help them with human-centered design. And it was really rewarding. And I think I just came to feel like I could still do good work and have more autonomy in my schedule. And I feel bad even talking about it, honestly, Gaurav, because I just feel like there's so many people who have no autonomy in their schedule. And there's so many people, of course, in our country who are a paycheck away, from eviction, who are working two jobs, who, cannot make ends meet and have no autonomy over their schedules. So I never want to talk about this without acknowledging that. And then I started to get more work. And then I started reaching out to my friends in the field and saying, hey, do you want to do some work with me? Because I have too much for me to do. And then I felt like, oh, I'm kind of building this little team again. And they're all so great and they're all so fun. That I think then that became its own draw is like, oh, I have a team again. And I think because it's something we talk about a lot is during the pandemic, we created the Lay Counselor Academy. And I think that work, the last sort of 5 years of my life, feels like it's been the most important work of my career. So then that has kind of its own draw in terms of staying in my own business.
Right. I want to talk about the lay counselor. Before you say anything, I'll say something. By the way, I remember you were giving a talk with some organization, maybe CPCAs, and you mentioned the lay counselor. No, you didn't mention the academy, but you mentioned the structure of how that team would work. And to me, oh, yes, that makes so much sense. I remember that moment and then kind of following it up and reaching out to you. And just before that, in 2021, when I was working with unaccompanied minors here in San Diego, we were told 3,500 kids in San Diego Convention Center, and San Isidro was like, can you do this? And they asked me, I said, yes, obviously, we're going to try and do it, but this is obviously on top of all the other work we're doing. I talk about this because if you're told you'll take care of 3,500 kids, you can hire all the therapists and psychiatrists of the county and you cannot reach one-to-one care. So the first couple days, we were doing sessions with therapists and we quickly realized that's not necessary or needed. And we quickly transitioned to our case managers, got them trained, see one, do one, and start running it. I would say within 4 to 5 days, we got to a place that we had 2 case managers running groups of 30 kids each and 4 groups a day. So we were reaching 120 patients, over 100 patients every day, with a therapist and psychiatrist with me available to see anybody with psychosis, very severe trauma, has more complex situations if they need one-on-one. So we were doing this 7 days a week. So we were reaching 800 patients a week. And by the way, this only happened because this was not in the health center. And nobody would tell me you can't do it this way. I know the resources I have, which are very limited, and I know what I need to get done. So I'm trying to do my best way to make it work. And I was thinking, once that project got done, I was thinking, why don't we do things this way in our health center, where the need is actually even greater? We are trying to serve 50,000 patients, and we have so long wait times. By the way, then that was a disconnect and I couldn't find a path. And when I heard you presenting, it kind of clicked that, okay, maybe this is a path. And I think we had a few conversations after that. So we launched the CCBHC and we launched it. And then once the lay counselor became something we can do, again, grant money allows you to do things creatively. People don't ask you how you're spending that money if they trust you. And so I think we said, okay, let's try a couple. And we knew the first couple people we sent to you, they already were amazing.
Yeah.
And I think we wanted to empower them and see how could they be even more supportive. And I'll tell you, the Lay Counselor Academy for our case managers, and they're still going from San Isidro, by the way, I know that. And I was thinking about the patient, but I'll tell you, I honestly was thinking about our team too. Them having done that has supported the psychiatrist, the therapist, all of the team members, not just the patient themselves. And it is a way, it has helped us kind of create a model where the patient has so much more support and contact with our team members who are now empowered and trained to do more because they're already doing more. Now we're just giving them this set to do it. Right? So it's been really an amazing way to build the whole capacity of our team.
I think like I don't want to let something pass before I just comment on it here, which is I love this story of them coming to you with 3,500 unaccompanied minors and you saying, yes, of course, right? Like, just like, yes, of course. That's the only answer, that you could possibly say is like, yes, of course, but then figuring out how to do it. And I do feel like, I mean, it's amazing. And these case managers, and we know that the single most important thing in all the helping professions for being effective is practice. And so group after group after group after group, you can just imagine how fast, that they were also improving in their skills. And then to have the licensed folks and sort of as backup. I mean, it's a beautiful model. And so, of course, you thought to yourself, why can't we do this in our health center? And like you hear that and you think, why can't we do this in this country? There's hundreds of thousands of people in any given community. I mean, if you're at a health center with 60,000 patients, 60% of those patients, 36,000 patients need behavioral health. That is the data. 50% of adults in the general population, 50% of our adolescents in the general population, not even in the Medi-Cal or Medicaid population. It is hundreds of thousands, millions of people, and this little drop in the bucket of the licensed folks that we have. And I mean, when you were just saying like the first people you sent to us, I know all of their names are popping up. And of course, one of them works for us now. We didn't steal them. I just want to tell anybody who listens to this that we didn't steal them. He's just doing work for us on the side. I mean, like we said, you sent these case managers who were already amazing. They were already highly skilled. They didn't have the license. They didn't have the master's degree. And yet they had the characteristics, the temperament, and the skills and the experience, right? They were very experienced helpers. And so it's a pretty short jump to mental health counseling from there. And then you sent the SUD staff. And as an addictions professional, I am always so troubled by the idea that the entire helping world can agree that you don't need a degree to help someone with an addictive disorder. One of the most complex mental health conditions, right? It's just incredibly complex. There's a lot of like risk, just like depression or anorexia. It's like there's high relapse rates, just like asthma and hypertension. Like it's an incredibly complex thing to treat. And somehow we've decided that those folks can't possibly help someone with depression or panic attacks. I mean, it just makes absolutely no sense. So of course I feel like where you and I meet, like our mind meld, of course you sent your SUD folks and they had all of the skills necessary already to be able to address people's mental health conditions as well. Lake Counselor Academy, we always say we're doing less teaching than we are reminding. Here's what you already know. Here's what you already do. Here's what you're already good at. And here's how it would apply to this. Here's how it would apply when someone discloses trauma to you. And then, of course, we're adding on and we're trying to, add to the toolbox. But a lot of it is reminding them what they already know and what they already do. And of course, someone who sees an addictions counselor who also has an anxiety condition would much rather stay with that addictions counselor and get care for both than have to be referred off to a wait list to separate their care. So it's better for patients and it just makes so much sense.
I was just thinking about this, that lay counselor is a solution. The health system, it devalues and overworks people at the same time. They tell them, you are not that important. Please do this also. I'm giving you more work, but you're not that important.
It's true.
Whereas the lay counselor, what it does is now, you're doing great work. I'm going to give you some more support and structure and things that maybe you've not had oversight and the weekly supervision, which is, by the way, I think such a great perspective, not for necessarily just for the clinical quality of care. It is a great perspective, making sure these people don't burn out because they maybe have not had that kind of supportive structure of feedback and all of that in the past.
Yeah, when people come through the Lake Counselor Academy, we meet with their direct supervisors and sometimes the leaders of those organizations to talk about this. We make a strong recommendation that every case manager and CHW and SUD counselor and health navigator and promotora and outreach worker who goes through the Lake Counselor Academy has weekly clinical support. And I don't say it this way, but really the kind of subtext is they should have always had clinical support because they are right on the front lines of hearing patients, community members disclose deep trauma, deep difficulty, complex depression, terrible life suffering. And many of them didn't have any clinical support. So they weren't meeting with a licensed person to help them protect themselves from vicarious trauma. They weren't meeting with a clinical support person who could say, you did the right thing with that, you did the right thing so that they could go home and feel peace instead of going home and wondering, did I say the right thing? Did I say the wrong thing? Someone who is there for them to talk through responding to someone who has suicidal ideation so that they don't have to be terrified, but that they can feel confident enough to say, I'm so glad you told me. Let's talk more about it. Instead of like smashing a panic button for someone to be taken to the ER, which we know causes more harm, but also for the person then to feel, to feel relief and some peace and to not burn out. And in the Lake Counselor Academy, we talk a lot about helping people manage distress empathy, that it's not the kind of empathy that's helpful when we feel the pain of others, because feeling the pain of others, it doesn't help the person feeling the pain because now they know that we're feeling their pain and sometimes they then want to take care of us. Like I always say, that one person in your life that you never want to tell you're struggling because you'll stress them out. And then that feels worse. We don't want to be that person to our patients. We don't want them to share with us. And then they see that we're like, oh my God. And they're like, oh no, really, I'm okay. They feel like they have to now take care of us. So it's not helpful to others, but it's, a cumulative feeling the pain of others leads to vicarious trauma when we're actually having the same symptoms as someone we're helping. Even though we didn't go through the exact same thing they did, now we're having the symptoms of that because by hearing the trauma, our brain thinks we've experienced it. And so we spend a lot of time like teaching people how they can protect themselves from that and maintain empathy. So we've both seen people at the, mid to late career that they've solved this distress empathy problem by guarding up and not feeling anything. That's not the solution. There's a middle ground though of perspective taking empathy. And there are tricks that we learn in graduate school to move ourselves out of distress empathy and into perspective taking empathy, which is the kind of empathy where we're with people like we were talking about at the beginning and where we can still feel with people and not be feeling the same pain that they're feeling so that we can maintain our stability and helpfulness. And I feel like a lot of these folks that we're talking about that come through the Lake Counselor Academy, they haven't had any of that. I don't think we've acknowledged, just like, I don't know if we do more now, but we didn't acknowledge that our primary care providers and our primary care systems were and still are the mental health treatment facilities in this country. I also don't think that we've acknowledged that the majority of mental health care is happening with CHWs, promotoras, SUD counselors, health navigators, community workers, legal aides, teachers assistants, first responders. That is the majority of our mental health help. And I feel like we haven't acknowledged that. And there's a lot of problems with that, but one of them is the great majority of people doing that work are people of color and women of color in particular. So it's like unacknowledged unpaid labor, and it's hitting a particular demographic that already has systemic inequities, already suffers from systemic racism and sexism.
Yeah, it's completely true. I think there are layers of thinking about people who are working in the system itself, what their role is, where they come from, and difference in if you're building a physical object in your work, there is a finite number of turns the screw takes. The work in healthcare is never going to be that predictable. Because even if the two patients' blood pressure is exactly the same, sugar's exactly the same, their home environment is different, how they got there is different, and that itself now all automatically changes how their illness is going to progress. Even if they are still taking the medication for the same time, there's no chance that all of those other factors don't have enough impact. So same thing for our team, right? I think a lot of times, unfortunately, also mostly because of financial pressure, people are having to make work their full life, which is not and cannot be and should not be ideally. Pandemic actually taught me the luxury of working from home. Like a lot of PCPs who had to work on site or hospital staff, I saw like there's so much happening in my kids' lives. There've been years I've just missed all of it. And there's so much going on. It's, oh my God, this is like, I'm missing all of this. And I think like building up with empathy for your team before for the patient is maybe a way to slowly get there.
Like what we're talking about. And particularly, I think that you really hold this perspective. It's really not just about us and our patients, it's about the systems. And we want empathic, human centered systems for our patients, of course, for community members, for us too. And we want empathy with our own teams and the different disciplines that we work with. It's just as important because patients can't get well and feel empathy in a system where people aren't being empathized with. There's like a trickle down effect of empathy, but there's a trickle down effect of dehumanization too, where if our providers feel dehumanized, then that trickles down to our patients. But the good news is empathy also trickles down.
Absolutely. And I think, again, one step back, you have to start with yourself. If you can't have it for yourself, you can't have it for your team. If you don't have it for your team, they cannot have it for your patient, and they'll have it for long term, and you will do it all, but then you'll burn out if you don't.
Yeah.
Again, we can keep talking for hours. Let me get to a couple of questions, and because I think about this a lot. Young healthcare professionals, what I'm excited about, I see a lot of passion, a lot of drive to want to make change much earlier than I had in my career. And I think that's a great change I'm seeing. But at the same time, they don't necessarily always have this broad system lens yet. And I think, obviously, like when you're talking, the lens is real broad. And what can young clinician, young leader who's thinking about wanting to make system change, how can they actually go about broadening their lens of how they view health systems?
Really an interesting question. Because I think often when people want to go into the mental health field or be a therapist, often what draws them in is that one to one. And a lot of what we've talked about today is that we want that perspective along with a public health, like a really broad perspective. Otherwise, we'd all end up in private practices seeing 10 or 20 people. Meanwhile, our country is, struggling with not a shred of access to even the most basic mental health care. I do think my kids are 16 and 21 now. So young adult-ish. And when I look at them and their friends, I do think that I see a more systemic lens in a different way that I think can be applied in the helping fields, which is they have a much more broad systemic lens around equity. And I think I think it's because there's probably so many complex reasons. I'm sure there's like better thinkers than me who have more ideas about why that is. But I think one of them that I can see is that Trump is their whole lives are Trump. 16 and 21, he was elected, when they were 6 and 10. And and he was running before that. So their lives have been with like this intense fascistic, misogynistic, deeply racist and cruel person and administration. And that has been their life in the US. And so I do think that when I talk to them and their friends, they have a much more sophisticated, big idea, broad lens about systems and inequities and poverty purposely generated in our economy. Like it's not accidental, it's purposeful. The income inequality and I think that they often, and this idea of social determinants of health, they might not use our same words because my kids aren't in the field but they do have an idea of what that means, that your zip code could determine your health, including your mental health.
Right.
And so I think that can be helpful because I think that lens, if you take that into a job where you're interning at a, therapy office for children or something, which seems very one-on-one. If you take that lens in there, then you start to wonder, not just about the people in front of you, but all the people who can't get in to see you. And then the people who stop being able to see you because they got kicked off Medi-Cal, then you start to think about what is of a larger system about, I can only see who has this insurance. I think it lends itself then to looking at the community as opposed to the people who walk through your door. And that's the lens that you have, I think, even more so than me, which is it's not the people who walk through our door. And it's not the people not the people who walk through our office door. It's everyone. When we think about like who we want to help, we want to think about these larger systems about people who are getting in. But I don't know. I don't know if I have hope. You said you see a lot of like, passion, and I do too. I do. I have one of my daughter's friends is in the Lake Counselor Academy right now. He's 25. He went to school for a year. He wants to be in psychology for all kinds of reasons. School wasn't for him. He has, learning struggles and anxiety struggles and all the reasons traditional schooling doesn't work for people. So when maybe back to growing up in Alaska, and like the trades, whether it's the Lay Counselor Academy or not, like this is just this program that we created, to train people how to do mental health counseling who don't have licenses and degrees. I'm just one person, or we're one little company. But I think on a larger level, we like to see this like skills over degrees as a movement. And there's an organization called Tear the Paper Ceiling that I think is more, kind of more of a movement where academic schooling isn't for everybody. There's a lot of systemic racism in academic schooling. There's a lot of systemic inequities. There's a lot of people with learning styles that can't flourish in those systems. There's when someone is 30 and they have kids and they're taking care of their parents and they're working full time, is it even possible to think about getting an LCSW, bachelor's and then a graduate degree? And some people do it, but we don't want to hold them up and say everyone should be able to do it. But I think there needs to be another path for people who want to be mental health counselors outside of academia, because there are people who have the right temperament, the aptitudes, the humility, and who have the skills naturally. I think there's just so many people who have those skills naturally. All of us can think of someone in our life. Like every time I talk to my daughter, I just think, you really need to be a therapist. She's like really good. And I don't think she's going to go to school, Gaurav. Like I thought she would, maybe because of me, but outside of me, there was really nobody, and who went to school, like her dad didn't. But I don't think she's going to. It's kind of not for her. And I'm just like, will she have a path in the helping professions if she doesn't? But I want there to be more lay counselors academies. I want there to be a real pathway for people. Academia will always continue to be a place where we can train therapists, but we're going to keep eking out insufficient numbers. We have vetted out people who don't learn that way, who are highly skilled and can help us help others in this country in this time of this mental health crisis that we're in. That is my hope, is a movement, where we're looking at people's skills and not just the letters behind their names.
But this gets me thinking a little bit, because lay counselor is again a great example, because I think all of us had this idealism streak when we were younger. When I first got into med school, that's all I wanted to do forever. And talking about money in healthcare was a taboo. I thought that's not a great topic. And then it took a while for me to understand, and especially in my leadership role, okay, I have to start thinking about money very early to do all the amazing things I'm trying to do here. But it's a very difficult path. I'm sure you saw, like I'm sure you had amazing ideas throughout your career where people told like, there's no money for this, or this cannot be done. So the system has a way of beating it out of you over time. And again, maybe two of us and many others who kept fighting that and try to figure out a way. Lay counselor is definitely a way that you can keep the idealism and still have impact and still have a path ahead. And there needs to be more like this in maybe all fields, and definitely healthcare. Let me ask you the last question. I know it kept you longer than we had planned. What is the most challenging and or exciting project you're working on currently?
Let me think about that for a second. I mean, the Lay Counselor Academy, it's really where all my heart and energy is going right now. And one of the things that we do in the Lay Counselor Academy is we watch a participant with an actor, and then we give them feedback on their counseling skills. And we've been doing that for a while now. But we are right now deep in this sort of evolving the LCA and looking at, different aspects of it and what we can make better. And this observation process, Grav, has been so successful. I thought it would be just like this really small piece and, people can volunteer to do it or not do it. But it has become this part of the LCA that people love, that they say was one of the most impactful things that they did. And it's just, the Lake Counselor Academy is 65 hours and the observation's 1 hour. It's really interesting, like what an impact it has on people. And what I've learned from that is that most people have bad to traumatizing experiences with being observed and getting feedback. And so people come into it so much more nervous than we ever expected. Sometimes they haven't slept the night before. Then we finally realized we had to start kind of prepping people before and talking to them about it and writing materials. We made videos of what it looked like. People talk one-on-one with us. They cry. Like they're so worried about it. And I have just heard story after story about people being evaluated in a way that was really traumatizing. And so we started to look at this thing and realizing that this isn't just about giving feedback to somebody. This is about helping people have a corrective emotional experience with what it can mean to have somebody observe you and, yes, evaluate you in a strength-based, loving way. Someone who already thinks you're awesome and great, who is looking at you through a lens truly of like love and respect. And then we give them this feedback that is totally strength-based. 80% of the feedback that we give is, I didn't know if you knew that you did this, but it is awesome. Here's like these things that you do. Here's something really unique about how you counsel that we want to make sure you know. Just seeing the impact of that on people has made us want to expand that part of the LCO. And I think one of the things that I could talk forever about because I'm fascinated with is the humility. And I'm learning like a lot more about humility and research that therapists without sufficient humility are quite dangerous. That having higher levels of humility, including higher levels of self-doubt, is related to how effective we are with patients. And it made me like reevaluate. Like I always leave a patient session being like, that could have been better. Or like, I wonder if I'm like not doing as much as I could. I wonder if that was, and then I like go talk to one of my colleagues about it. And I've been a therapist for like over 30 years. And sometimes I think to myself, am I ever going to think I'm a good therapist? But then I read this research and I'm like, oh, I'm so relieved. Maybe I shouldn't even try to get rid of that. Like, that's my friend. And so when we give feedback to people, we also get to see their level of humility. 9% of people who come through the Lake Counselor Academy have incredible humility, tons of self-reflection, really good amount of self-doubt. And we get to tell them, not only do we get to give them feedback, we get to say to them, hey, don't lose that. Being nervous around seeing patients, that's okay. That's your friend. Like doubting yourself, that's like good. You know what I mean? Like I doubt myself too. It keeps us consulting. It keeps us learning. It keeps us wondering if what we could do differently. And then like, there's like a tiny percentage of people that are arrogant and we think would be dangerous to patients, not because we've seen them be dangerous, but because we know that arrogance makes dangerous to patients. And so anyway, that's like one small part of the LCA that we're expanding right now. So people do multiple observations. And we're so excited about it.
That's exciting because I think the HCF leadership program also did a little bit of observing. I think if you trust the people who are giving you feedback, not just the teacher, but even your cohort, if you trust them, that whole experience becomes so much more positive than scary. Even though it maybe still be scary in the process, but after you actually feel really supported and listened and coached, right? The humility piece, I think about this a lot. I feel like courage and humility are the two cornerstone features I always look for when I hire somebody. If somebody thinks they already know everything, that's probably not the right person for most roles, any role in healthcare. And if they have courage, that is, they can jump into very difficult situations without knowing everything, but they know they have the support system. I think those two things really make an amazing team member because you are going to have very difficult situations that you've not been trained for, prepared for. And you hopefully have the courage to jump in, and hopefully you have enough humility to tell, I don't know this, can you help me? If you can do those two, I think you got it covered in most difficult healthcare situations.
I love that. Humility and courage. I haven't thought about courage in that way before, but I really love that. Thank you for sharing that.
Thank you so much, Elizabeth. It's a pleasure to talk to you always. I hope to connect soon. I am going to remind you to keep taking care of yourself because I think I love the way your brain works. And I want to keep having these discussions with you in the future.
It's a good encouragement. Thank you. Okay.
Thank you so much. You take
All
care.
right.